Thank you everyone for being here. I know the last close to 2 years we've been living on the virtual world, and I am just excited to have the opportunity to interact with you. We'll try to keep the talk to about half an hour, and then I'm really eager to hear from you and try to answer any questions you may have, and also, move forward the conversation around how we as neurologists and as a field of neurology can tackle structural racism. My disclosures here, they have already been mentioned in the prior slides. And I just want to take a step back and remind us that in 2021, there is a lot of evidence of disparities in neurology across all areas of neurology, whether you think about stroke or Parkinson's disease or epilepsy or pediatric neurological problems. There is in general enough knowledge now to show that people who identify as Black, Latino, Native tend to experience delayed neurologic disease diagnosis, worse clinical care, and at the end of the day, worse neurological outcomes. And there's many reasons for this, and certainly one of the reasons and one of the gaps that need to be tackled as we think of tackling structural racism is this tremendous gap we have in access to neurologists, particularly for people who identify as Black or Latino. So this is a project that I had the pleasure to do a few years ago with my colleague Altaf Saari, who's now faculty at Mass General, where we were very curious about who has access to a neurologist, and in particular, if people who are Black or Latino had access to neurologists with or without no neurological conditions. For this study, we used a medical expenditure panel survey, which is a national database. It has information of many people across the US, across insurance types. So whether you have insurance or you have public insurance or private insurance, you will be part of these data. And it is representative of the entire United States. So what you can see in these models, and if you look particularly at model 5, is that if you think about neurological care, for people who have no neurologic disease, people who identify as Black are 30% less likely to have access to outpatient neurologists, while people who identify as Latino are about 40% less likely to have access to outpatient neurologists. Now, as I mentioned, that is considering that they have no neurological condition, and also trying to incorporate other variables that potentially could be pathways to disparities. So this is considering people's age, people's level of function, and very importantly, other socioeconomic factors. And here, interestingly, you can see that there is a gradient by education level, with people with lower levels of education having worse access to outpatient neurologists. Also, there is a gradient when it comes to family income, with people of lower incomes being at a disadvantage when it comes to having access to outpatient neurologists. Important for our discussion later on, people who have public health insurance, whether it's Medicare or Medicaid, don't seem to be experiencing gaps in access to neurologists. And then really the gaps exist across the United States. Now, as I mentioned, part of this is not having an access to a neurologist. And what happened in that study that I shared with you just now is that even though these patients were not receiving outpatient neurology care, we could see through the data that it used to be that they would show up to emergency rooms or inpatient wards for treatment or evaluation of their neurologic conditions. And when you looked at cost, the cost for the care provided to these patients was actually even more expensive because of where they were receiving the care. Now, some patients do have access to neurologists, and then the question becomes, what kind of quality care do they have? Are we being patient-centered? Is the care we provide safe, timely, efficient, effective? And most importantly, is this being equitable. And so if you're not familiar with it, I encourage you to read something that's about 20 years old now, but very relevant still, the Institute of Medicine Crossing the Quality Chasm, that really examines our healthcare system and tries to discern how we can advance equity and in the quality of care we provide. So we've done some studies over the last few years looking at the type of quality of neurology care we provide to patients living with neurological conditions. There were a couple of studies that I conducted in partnership with our stroke unit with first author Betty Luan Urfe, who was a first-year medical student at the time. And Betty was very interested in looking at how we care for patients in neurology across language differences. And she wanted to know the answer to the question, if you suffer an acute stroke and come to an emergency room and speak a language other than English, how likely are you to receive thrombolytics? And the first part of the research that we conducted together showed that if you spoke a language other than English and you came to the emergency room with an acute stroke, you were not, there were no disparities observed in your probability of receiving thrombolytics. It actually was that people who spoke languages other than English were more likely to receive TPA, driven in part because they tended to come still within the acute treatment window and had more severe strokes. One of the thoughts that we had when we found that was that, acute stroke care in emergency rooms is very systematic, and that to some degree that probably helps buffer disparities. We still had an itch to try to really understand what could happen once someone left the emergency room and came into the inpatient wards, in part because knowing the literature across other areas of healthcare, we knew that people with limited English proficiency experience disparities. And so with this, we took the group of patients who had been part of the first study. We evaluated their care, the care of patients who spoke languages other than English, and tried to understand if the quality of the care they received was the same whether an interpreter was involved in their care or not. And there we realized that patients where we could not find documentation of a professional medical interpreter being part of their care were half as likely to meet the defect-free care metric for Get With The Guidelines. And this was driven by variables that in my mind have to do with communication, including discharge planning and stroke education. Trying to, again, think of the different pathways to disparities, and this will lead us to a conversation of how we can tackle inequity. One of the things that one of the students that I've worked with in the past, Dejara Johnson, who's now a neurology resident at Barrow, she was very interested in bias and stereotyping. And one of the observations in our team was that a lot of the times how we learn medicine, how we learn neurology may bias us unconsciously. For example, in the case of Parkinson's disease, the area of my subspecialty, it is often that picture on the right that is the image that we teach Parkinson's disease, and it is not representative of the population experiencing Parkinson's disease. So for this study, we sent out an anonymous survey to people across the United States working at movement disorders clinic, trying to discern how comfortable they were and how equipped they were caring for people across cultural differences. And among those questions relevant to today's talk, we found that more than half of participants, and these were physicians, nurses, physical therapists, and social workers, others working in movement disorder centers across the US, more than half of them considered that there was unconscious racial stereotyping that was common for patients in their practices. Alongside, about half of them also thought that patients from minoritized backgrounds were likely to receive lower quality of care because of their race and ethnicity. And when asked about any challenges that they perceived that could be tackled in their movement practices, one that came up frequently was that of poor access to patient materials in languages other than English. Now, speed forward to the current times and the COVID-19 pandemic. And if there had not been an awakening about racial inequity and racial injustice in society and in healthcare, COVID-19 has really amplified those disparities, and more than ever has brought urgency to the work ahead. I've had the pleasure to work with Lashira Nolan, looking at COVID-19 and the effects and the disparities in particular when it comes to neurologic disease. And what you can see in the few studies that I will share with you, just to really give you a quantification of what we're talking about when we say that we need to tackle structural racism. The examples that I will share with you show you how this diagram is very relevant, not just for COVID, but for our thinking of tackling inequity and the pathways to inequity. And you can see how society as a whole is organized in groups, and that these groups are given power, and some groups have more power than others, and some groups may be more likely to have access to resources, access to opportunities, be the ones making decisions. And this happens across society, leading to how we organize in our spaces, and for example, in our urban spaces, how we organize in our government, how we decide we will invest our societal budgets or economic, who will have access to economic opportunities, what kind of lived experiences we have, and important to today's talk, what happens within healthcare. Who is working in healthcare, who is scared for in healthcare, who has access or not access to healthcare coverage, to telemedicine resources, to transportation to get to clinic. All of those things together end up translating into health disparities, into missed or delayed diagnosis, missed or delayed treatments, and unfortunately increased morbidity and mortality. And as I mentioned, this is true in the field of neurology. This is a study from early in the pandemic. Centers across the United States and Canada evaluated people with COVID-19 and stroke. And looking at the data, the investigators realized that patients in that sample who identified as Black were twice as likely to die compared to other patients. And this was not because of them having more severe comorbidities, or how severe their strokes were, or how fast they came to the emergency room. But it seemed to the investigators it had to do with access to resources in the hospitals that they were presenting to, including lower rates of receipt of thrombolysis and lower rates of receipt of thrombectomy. Now, this is a different study, a large study in a large academic medical center in the United States, where the investigators were interested in understanding the neurologic manifestations of COVID-19. They were intentional, again here, about evaluating potential disparities. And this really stemmed from prior work they had done before COVID, where they had seen some inequities in the treatment of patients. So in this study, it's about 500 patients, and they realized that patients who were admitted at the academic medical center of that health system, compared to those who were not at the academic medical center, were likely to do better. So those at non-AMCs had much worse functional outcomes and had an increased rate of 30-day mortality. Again, this wasn't because they had more comorbidities or because they had more severe COVID. When the investigators analyzed and discussed this data, it seemed to them that the disparity could be driven by lower access to critical and specialty care, as well as differential assignment of goals of care orders. Now, if you move from the inpatient to the acute, and here I'll use the example of the Teletroke networks. There is data too, and as you may remember, early in the pandemic, there was about a 20% decline in emergency room visits for people experiencing acute stroke. And there is national data suggesting that people who identify as Black or Latino were more likely than others to not come to the emergency room. And what we see in this analysis of a telestroke care network in South Carolina is that people who, so the number of consults decreased, but the greatest proportion was that for Black patients who had the greatest gap in consults. Now, if you move to the outpatient setting, it's important also to think of neurology not just in the United States or in North America, but throughout the world. And this is a study that is international. I should say, though, it's a web-based survey, so it did require access to digital resources, but where there's over 5,000 people with Parkinson's who were not known to have COVID-19. And they were asked about, their experiences with health and healthcare during the early part of the pandemic. And one of the things that, again, here, the investigators were intentional about was exploring potential inequities. And they observed that households or patients living in households with lower household income were more likely to have gaps in access to care. They had more troubles attending telemedicine appointments, greater difficulties getting refills, and were less likely to find alternative ways of exercise. As I think of these different barriers, I really think this is the tip of the iceberg, knowing that it's an electronic survey, but just highlighting how the problems are pervasive, from the emergency room to the inpatient wards, to the ICU, to, in this case, the outpatient clinic. And COVID is one example. As I've mentioned to you, the inequities exist across neurology well beyond the COVID-19 pandemic. But when we read about COVID and inequity, and when we read about a lot of the other problems, we're thinking about outcomes usually like mortality or morbidity. But it's really important to think of these as the tip of the iceberg, and think and recognize, take a step back and remember that our patients and their families and their loved ones are often also experiencing food instability, housing instability, job instability, and these have all of these economic and other hardships have been magnified in the pandemic. So whether someone has COVID-19 or neurologic disease, or the intersection of both, in 2021 and in the years ahead, we will be dealing with all these factors that are really understudied at this point in time. And so as we think about how to tackle structural racism, I just want to remind us about the healthcare system in which we live in, and the society in which we live in, where things have been built in a way that favors some and not others. And the system from the start has been built in a way where some have easier access to tools and assistance, and some are really up a hill. It's really harder to navigate our health system, to enter our health system, to navigate that health system, to receive what we need in a timely manner, and at the end do well. And a good example of this diagram and the differences in this diagram comes from the COVID-19 pandemic. At our hospital, as it happened in many other hospitals across the US, we suddenly, early in the pandemic, had a surge of patients who spoke languages other than English. At our hospital, the search was so large that our professional medical interpreter's office did not have the bandwidth to properly care for all of these patients. And so you can see that, our system, and if you think about inequality, our system has been really shaped in a way that expects patients to be speaking in English. And when someone doesn't speak English, particularly when someone has limited English proficiency, there are mechanisms that try to achieve equity. In this case, bringing a professional medical interpreter or a linguistically competent clinician to come and provide the same care with the same quality. So as I mentioned, in our hospital during the early part of the pandemic, the equity intervention really wasn't enough for the magnitude of sudden surge of patients we were caring for. And so what happened is our chief equity officer called for Spanish-speaking physicians, mainly because that was the #1 language that that people were presenting with, to come and be embedded in COVID-19 care teams. And several of us in neurology were part of that Spanish language care group. At the end, the search kind of faded away. The work group disintegrated. Everyone had their own areas of clinical focus that they needed to return to. And we were left with the question of what will we do when this happens again? And how can we walk towards justice? How can we, recognizing that this system has already not been sustainable, how do we fix the system? How do we go beyond what we have now so that everybody can have access to the opportunities and tools that they need? So whatever language a patient speaks, when they come to our hospital, they will receive the best possible care. And so what this has meant intentionality, and it has required a significant financial investment by a health system that is really revamping interpreter services, hiring more people, and really being more conscious about the linguistic diversity of the clinical workforce and how that can potentially be increased as well. Now, I think it's critical to talk about segregation and injustice when we talk about advancing health equity. And these are two examples that are important to think of. Segregation happens within cities, segregation happens across our country, and this segregation is pervasive and it affects our access to education, or access to transportation, or access to jobs, and importantly, your access to health and healthcare. And some of you may be familiar with the map on the left. It's the map of the subway system in Washington, D.C., where you can see that depending on where you live in that subway system, your life expectancy can vary about a decade. And with the more resourced areas in that map, people living longer. The map on the right, most neurologists are familiar with. It's the stroke belt. It's the that area in purple is the area of the country where people tend to have a greater chance of having a stroke at a younger age, and dying of a stroke. And while there's a lot of factors that lead to that, it's important to really underline that a big contributor is gaps in access to economic resources, economic opportunity, and really subpar access to wealth. In the context of the COVID-19 pandemic, segregation has led to health injustice. This is a map of the city where I live in, Boston, where you can see that the areas of Boston with the highest levels of poverty, which are the same areas that are the highest areas of where people of color live, are the places where there has been a greatest impact by the COVID-19 pandemic. And so racism is a determinant of health. And as we think of tackling structural racism, you can see from this image from the World Health Organization that we need to think of the health system but we also need to think well beyond the walls of our clinics and our hospitals and think of who we select as leaders for our government, what kind of public policies we have, including importantly, what type of health insurance coverage policies we have, what material circumstances our patients and their loved ones live in, what are some of the challenges that then can affect their health and their access to healthcare. And this is a pyramid I like to use from the Centers for Disease Control, which is a framework for public health action. And the biggest message with this pyramid is everything in the pyramid matters, things at the top and all the way to things at the bottom. As you go down in the pyramid, you will have a greater population impact, although it will be there will be more effort and there will be need for more resources, but this will pay off. I won't talk today about counseling and education and long-lasting protective interventions, although I would say that in the field of neurology, the long-lasting protective interventions are vaccines for polio and nowadays vaccine against COVID-19. I will focus on the clinical and policy and socioeconomic factors that we as a neurology community can leverage on to dismantle structural racism within and beyond neurology. One important thing as clinicians is thinking of the healthcare system and how we can desegregate it. And I think there's three parts to the approach. The first gap, which we observed in the research with Dr. Altaf Saadi, is the gap in access to neurology specialists. There's certainly concentration of neurologists in urban areas, gaps in rural areas. And even when you look at cities, large cities, there is, as you saw in one of the studies that had to do with COVID and Chicago, there is differential access to neurologists depending on where you live in a city. So I think we have an opportunity as a field of neurology to shake things up and to think of how neurologists can practice outside of the places where we've traditionally practiced. For example, within community health centers. And to give you an example of how this can be done, our healthcare system, Mass General Brigham, now has 3 neurologists practicing in community health centers that offer neurology evaluations and neurology care to patients within their communities. I think this has to also apply to community hospitals. And one of the opportunities there certainly is for being more intentional about employing neurologists in community hospitals, but we can also be creative and leverage on telemedicine and foster connections between academic and community hospitals, just like now with the existence of acute telestroke networks, really bringing that to the 2.0 and 3.0, where we can provide neurological evaluations and care through telemedicine in emergency rooms, in inpatient services and in intensive care units. This is being done in several networks across the country, including one that I'm really proud to be a part of, the routine and urgent teleneurology network that Mass General Brigham leads, providing access to neurology services at community hospitals in New Hampshire, in Maine, and in areas of Massachusetts where there are no neurologists working within the hospitals. Now, access to a neurologist is not, it needs to be complemented with access to neurologic diagnostics and tools. And what I mean by that is, if as we expand access to the clinical services, we need to expand access to EEG, to EMG, to CT, to MRI, to neuropsychologic testing, to sleep studies, because only there will neurologists working in the community will have access to the resources they need to appropriately diagnose and treat patients. These resources should be within communities and for those communities. In addition to that, there's a lot that we need to do to further diversify the neurology workforce. And here I'm not just talking about neurologists, I'm talking about nurses, I'm talking about clinical research coordinators, I'm talking about neuropsychologists, everybody who helps support the care of people living with neurologic disease, because a more diverse workforce will allow for better building of bridges with communities, will allow for better care at an individual level, including as it comes to powerful tools such as language abilities by clinicians. Finally, I think in 2021, it's super critical for everyone training in neurology to understand issues of equity, diversity, and inclusion. And I'm really grateful to the American Academy of Neurology for offering webinar series like this and other programming, including at the annual meeting, to help us move forward as a field of neurology, learning more about equity, diversity, and inclusion. I think this is critical. And I'm happy of the efforts of people like Jillian Berkman and Mass General Brigham, who've developed and implemented curriculum on health equity for trainees to learn through their training years. Now, when I think about healthcare, I also think about how our healthcare system lives within a broader society that decides to invest or not resources in tools that are needed to move healthcare effectively. One of them is universal healthcare, and we'll talk a little bit more about this. But as of 2021, there are about 31 million Americans without health insurance. And if you go back to the medical expenditure panel survey data that I shared with you, that is a problem. That limits our ability to connect people living with neurologic disease to outpatient neurologists. So we need to find a path towards universal healthcare. Second, telemedicine licensing reform and telemedicine laws and regulations. Right now, we know that it can be done, but we have barriers that need and can be overcome, including access to broadband for communities, particularly communities of color, and communities where there is less access to resources, access to computers and digital devices, and then thinking about the different laws and regulations across states and licensing across states that are currently potential barriers for what could be an expansion of telemedicine that helps tackle equity, particularly when you think about states where there are large rural areas or areas where there is just less access to care. This potentially could be a great solution. And finally, public health infrastructure. We need, as neurologists, to learn and think about where hospitals being built, where hospitals being closed down. What does that mean for access or lack of access to neurology services? How can we be more intentional as a society to set up the public health infrastructure that we need to really succeed in diagnosing and treating and caring for people with neurologic disease? I'm very proud of everyone doing advocacy around these issues. I'm grateful that the American Academy of Neurology has Neurology in the Hill, the Paralushi program, and other ways of really helping us acquire tools as neurologists to move conversations forward, including at the state and national level. Now, as I mentioned, context matters, and insurance or lack of insurance is a big problem in the United States, where about 10% of people ages under the age of 64 are uninsured. And what you can see on the image on the left is that when you look at who is uninsured in the United States, a lot of people are actually working, and some of them in their household, there's more than one person working full time. this happens across family income levels. And very importantly, it overburdens people who identify as Black or Hispanic or Native Americans. So there is structural racism embedded in the conversation of who has insurance and who does not have insurance in this country. And when you look at the map on the right and you think about segregation of resources, including segregation of health insurance as a resource, you can see that the areas in green are the places in the US where there's the greatest gaps in access to healthcare coverage. And in my imagination, when I try to overlap it with the map of the stroke belt, it actually overlaps, not completely, but it overlaps quite enough. Now, lack of insurance really translates into lack of diagnosis and lack of treatments. And you can see this survey by the Kaiser Foundation, where people under the age of 64, and this is because 65 and over Medicare kicks in, but under the age of 64, people who are uninsured are very likely to not see a doctor at all, not have a usual source of care, so usually not having a primary care doctor, very likely to postpone seeking care because of cost, or going without the care that has been advised because of cost, or just delaying a prescription refill because of cost. This is something that can be changed. And I believe we as neurologists, as a neurology community, have an obligation, a responsibility to learn about insurance and health insurance gaps and how there's different proposals that are being considered to change this. And for all of those who like history, if you go back to President Johnson time when Medicare was implemented, you can see how this takes intentionality, right? So at the time, it was the president who helped move forward Medicare, but there was a huge social movement, including by a lot of physicians and nurses and others in healthcare who advocated for better access to resources that would allow people to receive diagnosis and receive care. Now, poverty is also very pervasive, and there's certainly an overlap between the different factors that we've talked about. You can see on the right, this is data of the poverty rates in the United States. And you can see again the intersection between race and poverty. So people here in 2019 who identify as Black or Hispanic, people who have no high school diploma, people who are immigrants are those who are most likely to be experiencing poverty. And so when we think about this interventions, when we think about how we as a neurology community, we as individuals can help dismantle structural racism, we need to be thinking about the opportunities that we can offer others to advance their education. We need to be thinking about the jobs that the institutions where we work offer, the jobs that we offer in our labs, in our clinics, in our lives, and are those jobs coming with living wages, good benefits, etc. Finally, we need to learn about social issues that are very relevant to public health and to advancing equity, including residential desegregation and reparations, which I believe are critical to truly advance equity, including health equity in the United States. So as you can see, we've walked over the last few minutes on the problems, but also pointed to some of the solutions. And part of the message here is we all have power to contribute to dismantling structural racism. And while there are many barriers and they occur across society, and not just within healthcare, but outside of healthcare, we all can do our part by identifying, quantifying, and finding pathways to tackle these inequities so that we can help reduce the missed or delayed neurologic diagnosis and the increased morbidity and mortality that people of color currently experience. Now, I close with a picture of one of my heroes. Miss Cunningham Terry passed away early in the pandemic because of progressive supranuclear palsy. And she, when she was a little girl, grew up in Boston, looking around her built environment, realizing that there were not people or images that looked like her. And as she grew in her education path, she became a sculptor and applied her talent as a sculptor to right the wrongs of society that she had witnessed growing up. And thanks to her, the city of Boston is peppered with beautiful sculptures of Black leaders and Black people in our society. And so I ask you and I encourage you to join me and many others in neurology to right the wrongs of society, right the wrongs of healthcare, and move forward with intentionality to together dismantle structural racism and advance health equity for our patients and for everybody at risk of neurologic disease and experiencing neurologic disease. So this is the end of my slides. I really appreciate you being here. I appreciate your time and interest, and I am happy to take any questions. Thank you.
We'll ask people to put any questions that they have in the Q&A section, and then we'll be trying to answer them one by one. I guess as people get started, Dr. Mejia, can you just tell us a little bit about how the path you took in your career and how you ended up where you are for people that are early career and are wondering how do we get to the point where we will be giving talks at the AAN at diversity webinars in the future?
Absolutely, happy to answer that question. I'm from Guatemala. I grew up in Mexico. In both countries, and in the country of El Salvador, where my dad is from, I witnessed really stark inequity. And I went to medical school in part to tackle that inequity. And when I came to the US, I thought that, with more resources here, I would not necessarily find the disparities that I was seeing in Latin America. And, unfortunately, that was not true. And from the early on in my residency, I realized that people who are Black, people who are Latino, people who are Native, people who are uninsured or underinsured, or with other, disadvantages are really struggling to receive neurologic diagnosis and be treated with equity. And so it was at the end of residency, when I had some elective time, that I did a lot of reading and soul searching, to be honest, because it felt to me like the solution, as best as I tried to give all I had a patient at a time, I was not going to move the needle enough. So I learned about health disparities research. I realized that this field was really advanced in other areas of medicine, like cancer, like HIV, like cardiovascular disease, but that there was very, very little in neurology, and this posed an opportunity. That meant going back to learn and get a master's in public health and the postdoctorate degrees that you mentioned, which really helped me get tools like better knowledge of epidemiology, better knowledge of statistics, and mentorship, which is really important, connecting with others in this space, a lot of them not necessarily in neurology, but who were moving forward in equity research and equity work in other fields, to learn from them and learn how we could how I could contribute to this work in the field of neurology. I think for those of you interested in health equity, what I would say is, for me, while it's been important to help document some of the inequities, I think there's a much greater urgency in tackling those problems and developing solutions, whether it's in clinical care or in community work. but really trying to build off, not just staying in, let's document the problem and keep documenting the problem, but let's put resources to work to move the needle.
Another question was, how do you take into consideration where people live and their level of income when doing some of the studies that you've done?
Yeah, so thank you for that question. And I saw a question in the Q&A there. It's actually interesting. The medical expenditure panel does have questions around geography and does have questions around income. So the person who shared the question, they're right. They are confounders, and we accounted for them, whether it's by region, by income level. And so it's important to know that a lot of the times in health disparities research, when you're trying to use data from across the country, you're relying on whatever data is collected or not in these national surveys. So it's important to, for all of you doing research, to advocate for including variables that have to do with equity. And once you include those variables, to analyze them and report them, including race, including socioeconomic variables, because that is what helps move the conversation forward. For one of the studies that we did, or for the studies that we did around language differences and how we care for people who have strokes, we used Get With the Guidelines, but Get With the Guidelines does not have language data. So we had the job of putting Get With the Guidelines together with language data and interpreter services data from our system. Wouldn't it be great if those large databases had, for example, information on language among other variables?
Another question was on how the partner system tries to promote health equity within different departments, specifically the neurology department. Do they do holistic interviewing of residents? Do they provide clinics for underserved populations?
Yeah, so these are great questions. And what I would say is, I think equity and health equity is in constant evolution. And when you look back at what has happened in the healthcare system where I work, for example, for decades, there have been efforts that have been not well integrated with clinical departments. So for example, we have a Center for Diversity and Inclusion, we have a Center for Community Health Improvement. They do really amazing work and they've been doing it for decades. But the connection or the engagement with the different departments wasn't there at the beginning. And so one of the things that over the years, we've been more intentional as a system is to make those connections and to have leaders in community health and leaders of diversity across different departments, including in neurology, where I have those roles, thinking of the problems in our community and the initiatives across the system and in our hospital, and how we as a Department of Neurology, for example, can contribute to whatever needs to happen. So part, I think, of the change over time has been the restructuring of who's involved in the health equity work and what resources are allotted to health equity. And our system, a couple years ago, there was the appointment of our very first Vice President and Chief Equity and Inclusion Officer, which I think really opened the door to a lot more resources, including a team and a budget that focuses on equity. Same thing has happened at the system level, where there's a new leadership team with lots of resources. Part of these resources, I think, very strategically are being shared with community organizations. So the money is being diffused across our community and in partnership with others who've been doing work for a very, very long time. Part of the question also had something around, there were several parts to this question, so I don't know if I've answered all of this. Oh, yes. There's a lot we do with regards to recruitment, retention, advancement. And I think it's kind of a whole question in its own, but holistically, everyone is evaluated, and there are steps in the process that we implement to to maximize equity. And some of these resources that we apply are publicly available through, for example, the AAMC that has some guidelines on how you can maximize equity in recruitment.
Another question is, can we move beyond research that focuses on describing the inequities and disparities that exist, but rather producing solutions to those inequities and disparities?
Right. I think it takes intentionality. I think it takes us saying there's enough data already. We don't need data specific to 2021 or 2022 or this particular subgroup. Let's use this as our background. And if you think about research in other areas, there's a lot of background data that we say, okay, this is what exists, and we built from that. So I think part of the how is being okay with some of that background data, maybe not being decades old, maybe not being super detailed, but showing disparities that are stark enough that what we need now is action. And I think we have a lot to learn from other fields on how they have deployed action. And so, for example, there's a question on the chat, I believe, about community health workers, patient navigators. Those are certainly very concrete actions to help that have been very fruitful in other areas. A good example of that in the community health centers at Mass General Brigham, there's plenty of data that how using patient navigators has helped actually eliminate cancer screening disparities. So a lot to learn from other fields, and potentially to partner with leaders in other fields that are doing intervention focused research.
I guess one other question is, in terms of access to healthcare, how do we mitigate that in sort of lower and middle income countries that may not have resources or the resources of a country like the United States?
Such a great question. And I think, as I mentioned to you earlier, this is really about people, and this is about putting people at the center of everything. About a month ago, I lost someone very dear to me in El Salvador because of a stroke. And it was a reminder of this question. It was hard for them to have access to a CT. It was hard for them to have access to a hospital, to someone monitoring their blood pressure. Certainly there was no visiting nurse system that was in place to help them and their family as they had hemiplegia. There were gaps in diagnosis and treatment, and kind of in the longer term support. And this is true for many countries in the world. And so I think it's our responsibility as neurologists and as a field of neurology to unite. And these are problems that happen everywhere. We've talked about language today. When I present my research on language at international conferences, I hear from people in Australia, in Europe, that are facing the same problems, and so on. So I think we need to think of neurology as a global field, and think about equity as a global problem as we define solutions.
I guess one final question is, if you could give one piece of advice to people joining this webinar in terms of seeking to help repair some of these disparities and inequalities, what piece of advice would you give them?
I think all of us have the power to advance equity every day with our actions, and there may be simple things. For example, when you are in the clinic or in the emergency room caring for someone and realizing that they have limited English proficiency, making sure that you engage an interpreter if you're not fluent in their language. That is something very concrete that you can do on your day-to-day. Two, engaging in the conversation at the hospital and in your healthcare systems of what are we doing for equity? Who is doing it? What is being done about neurology? How can we make a connection between what's happening across the system and in the department? And then finally, learning about the bigger challenges that I think are the ones that as I mentioned in the pyramid, will take the most effort and resources, but will have a really positive effect, including, for example, learning about universal healthcare and how we can find a path to achieve it. And nowadays, telemedicine reform, I think that's another very big one.
Well, thank you, Dr. Mejia, for joining us today and for your incredible presentation and for answering all these questions. And that last piece of advice, I think, is really something we should take to heart. And thank you all for joining, and hopefully you'll join us again in our next event next year in 2022. Everyone have a good night.
Thank you, everyone.